Thank you, Dr. Mon. Good morning. Dr. Ferreron, I would like to thank the organization committee for inviting me to take part in this very important meeting, this joint session with MILAN and SOLAESE, the Latin American Society of Cardiac Medicine and Electrophysiology. Can we start the presentation, please? And the topic is challenges of ablating outflow-tract ventricular arrhythmias. My interest. According to the survey published by MILAN, the prevalence of idiopathic ventricular tachycardias was 11%, and outflow-tract ventricular arrhythmias are included in this group. And according to their localization, the arrhythmia may be originating in endocardial alveoli, pulmonary artery, endocardial alveoli, aortic cast, aortomitral continuity, and less frequently epicardial, great cardiac vein, and then ventricular summit. Now, I am going to talk about catheter ablation. Why is it a challenge, and how can results be improved? In our experience, there are some rules to approach these patients. The first is the clinical knowledge of the patient, the symptoms, the type of arrhythmia, the complementary method of diagnosis to evaluate the anatomy of the patient, and the possibility of arrhythmia-induced ventricular dysfunction. The second rule is to know the electrocardiographic characteristics. It is frequently a challenge, but it's very important due to three reasons. The first is to choose the best approach, the localization of arrhythmia origin, and to counsel patients about potential risks, for example, ablation in the aortic fluid. We prefer to use the ECG analysis proposed by Dr. Mandiski's group. In this scheme, I represented the anatomical structures in the awful tracts. This is anterior, posterior, right, and left. The most anterior structure is the arbitral wall, and the most posterior is lateral mitral annulus. You can see here different base maps in the same patient from RBOT to mitral annulus. In the frontal plane, you can see in lead 1 becomes marked negative from RBOT to mitral annulus, and lead 3 becomes more positive than lead 2. In the precordial leads, you can see later precordial transition in the RBOT with left bundle branch block, and here in the mitral annulus, early precordial transition with right bundle branch block. But a lot of indices have been described, but their analysis is not the objective of this presentation. The third rule, and probably the most important rule, is to perform a careful mapping. We can use conventional techniques as phase mapping. You can see here PVC originated in left coronary cusp, and here phase mapping 12/12 match, or the activation mapping. You can see here PVC originated in the right coronary cusp, and here earliest activation time in the site of successful ablation in the right coronary cusp. Probably the fourth rule is the superposition of techniques. As you can see in this patient with high burden of PVC and ventricular dysfunction originated in the left coronary cusp, here PVC, phase mapping 12/12 match, earliest activation map in CARDIOSTIM, and here superposition of techniques, stereotaxis, CARDIOSTIM, and ablation catheter in left coronary cusp. Some maneuvers can be useful to differentiate right origin from left origin. This is frequently a challenge too. As you can see here, in the case of unsuccessful ablation, in the right ventricle, as you can see here, can be used for mapping the opposite side, as in this case, with unsuccessful ablation in the RBOT, but with successful ablation in the right coronary case. The radioscopy shows ablation catheter in the right side and ablation catheter in the left side. Or mapping in the coronary sinus, as you can see here in this image, early activation map in the distal coronary sinus that suggests a left origin. In this case, the arrhythmia origin was in the left coronary case. Or the isochronal map can be useful in patients with V3 transition and septal early activation. Both isochronal maps were performed in the RBOT, but if the isochronal map had this morphology with small area, the arrhythmia origin was in the RBOT. On the other hand, if the isochronal map had this morphology with a longer perpendicular axis and an area mark more than 2.3 square centimeters, the arrhythmia origin was in the RBOT. This important information can be useful to avoid extensive ablations in the RBOT. Or, as was shown in this very nice case, sometimes we have right and left exit side. You can see here typical electrocardiogram from the RBOT, and during the application of radiofrequency, here you can see V3 change to predominantly positive in the set during the application of radiofrequency. In this electrogram, you can see precordial transition V2, V3 versus V3 before. In this case, that suggests a left origin, the successful site for ablation was close to the left coronary cusp. This case shows the close anatomic relation between the anatomical structures in the outward tracts. Some specific tools, as the multi-electrode mapping, can be useful in patients with isolated PVCs or non-inducible arrhythmia, in this case, the NSI-array system, or the new irrigated multi-electrode catheter for mapping and ablation, in this case, ablating in the poles 3 to 4 in the RBOT. The definition of acute successful ablation is the complete abolition of the arrhythmia. As you can see, in this case, during the application of radiofrequency, you can see the modification of arrhythmia until its complete abolition. In this case, ablation in the RBOT using the simplified approach. Well, what about failed ablation? In this very important publication from Dr. Morales' group, they include patients with RBOT-like ventricular arrhythmias and failed ablation, and they found that in 74% of the patients, the arrhythmia origin was not in the RBOT, and the most likely explanation for the failed ablation was imprecise mapping. Due to that, they proposed a step-by-step approach in these patients. First, perform a careful RBOT mapping, then pulmonary artery mapping, then coronary venous system mapping to evaluate the epicardial origin, and finally, aortic cusp. Avoiding complications. Some maneuvers can be useful to avoid damage in some structures as the coronary arteries. As you can see here, ablation in the right coronary sinus, early activation map in CARDIOSTIM, and here the radioscopy shows ablation catheter in the right coronary sinus and right coronary artery with the angiography to avoid its damage. What about results? Several years ago, we present the experience from Dr. Brugada's group in the treatment of idiopathic ventricular tachycardias. We include 35 idiopathic VTs, in which 80% were in the outflow tracts, and the efficacy was 87% using the simplified approach. Now let me show you data about our first Latin American catheter ablation registry published in Europace 2 months ago. We include 13 countries, 120 centers, and more than 50 tons of procedures, in which 728 PVCs and 280 idiopathic VTs were included. And the success was 86% in idiopathic VT, and 83% in PVCs. The complications were 3%. Now let me add a few words about the very interesting clinical presentation of arrhythmia-induced ventricular dysfunction. Several years ago, we presented our experience in patients with high burden of PVC and ventricular dysfunction that improved the ejection fraction after ablation. And more recently, we performed a multi-center study with the groups from Barcelona, from the Netherlands, and our group in Argentina, published in JACC. And we included patients with high burden of PVC, the ventricular dysfunction, with and without structural heart disease. This study, as we know, is the first study that includes unselected patients with and without structural heart disease. And we found that in patients with sustained successful ablation and high burden of PVC, the cutting point was 13%. They had improved the ejection fraction, had improved the functional class, and had improved the PMP levels in the follow-up. The importance of this study is that identified as a group of patients with high potential benefit of catheter ablation. The question probably here is, should we assess the PVC burden in all the patients with ventricular dysfunction? Probably the answer is yes, but further studies are needed to confirm it. And finally, let me comment about a very interesting field of investigation, challenge study. We performed this multi-center study that was presented in these scientific sessions. We included 62 patients with primary prevention indication for ICD implant and high burden of PVC. We performed ablation in all of them, and we performed a follow-up 6 to 12 months. In patients with sustained successful ablation in the follow-up, 63% of them removed the indication for primary prevention ICD implementation. Due to that, they improved the ejection fraction and they improved the functional. In other words, ablation can avoid unnecessary implants of ICD. It's a challenge proposed, but it's a very interesting topic to evaluate. Again, should we assess the PVC burden in all the patients with primary prevention ICD implant indication? The answer probably is yes, but again, further studies are needed to complete. Ladies and gentlemen, in conclusion, in the challenges of ablating outflow-tract ventricular arrhythmias, it is important to know the clinical characteristics, the electrocardiographic characteristics, the mapping techniques, the combination of techniques, and we may summarize the message. In 4 words, we need training, which means education, we need technology, as I showed you, we need working in a team, and we need time to assess the patient in a case-to-case basis to achieve our best results. And thank you for your attention.